In this video, I want to show you how to do DMEK in 4 minutes. And it's not because there's any prize for going quickly or rushing through an operation, but just because DMEK has this reputation as being this really technically challenging operation that people have to psych themselves up mentally for. For a lot of patients, it's this daunting prospect of a corneal transplant and oh my God, it's eye surgery. But actually, the operation for most patients can be this really quick, easy procedure. It's not this big, giant ordeal undertaking in the vast majority of cases. There are just a handful of little tricks and tips and efficiencies that you can employ to make the operation actually probably quicker than almost anything else that's done in a procedural room. So we do the surgery under topical anesthesia, supplemented by a little bit of a sub-Tenon's block for most patients. This is a 30-year-old woman being operated on in our office for Fuchs dystrophy. She's phakic. She has not had cataract surgery already. She's just had a little bit of oral Valium, so there's no IV. And we're doing the operation. I'm making 3 paracenteses with a 15-degree blade and then inflating the anterior chamber with a preservative-free lidocaine. This is a 3mm keratome. And I like to make the incision and then widen it a little bit. I like a big wound. And the reason is with a big wound, the injector is easier to insert and the wound is less likely to leak. Paradoxically, with a smaller wound, you have more stretching and gaping. So with a large wound, you get better sealing of the incision. I have an anterior chamber maintainer connected to a 60cc syringe, which is being held by my assistant, and he or she is depressing the end of that syringe, and that inflates the anterior chamber with air. And the reason I like to do my decimetorexis under air is the visualization is better, so you can see Decime's membrane. You don't leave little shreds or remnants behind. And it's more cost effective. If you use viscoelastic, you have to pay for the viscoelastic, then you have to pay to remove the viscoelastic with the irrigating aspirating handpiece. There's a setup involved in that, which takes time. Whereas with air, not only is it quicker, but actually you can see what you are doing better. You're less likely to leave little shreds or remnants behind. Now, my assistant, as they depress the plunger, they tell us when the plunger gets low, when the air is low in the syringe. So then I just wait, I pull my instrument out, they reload the syringe, and then I just go back in to finish stripping. So typically I strip all around in the periphery. I do a large diameter decimetorexis, not only because I like to use a large graft, but also because it makes your centration less vital. If you've overstripped the Decime's membrane, that means you have to be a little bit less precise with centering the graft in the eye in order to avoid overlap, and that just prevents you from getting detachments. So I've stripped all the way around now, and I remove this little wad of Decime's membrane from the eye via the main wound. And usually after I do this, I'll go back in and clean up a little bit with a scraper, not to roughen up the stroma. I think that's really important to avoid, but just to make sure I don't leave any little tattered remnant shreds behind that would interfere with attachment of the graft. So after that's done, the next thing I'll do is we will swap this anterior chamber maintainer out. My assistant fills up the syringe with saline, and here I'm injecting some more lidocaine in the eye. The reason is I'm about to do my iridotomy. So I don't want to do that under air because then you can't really see the movement of the iris. You want to do it under saline. So we're going to put the anterior maintainer connected to saline, and I'll replenish the lidocaine to make this comfortable for the patient. Now, the device I use for the iridotomy, this is the capsulotomy device that comes with our Ertley phaco machine. It's designed for capsulotomy, but it makes a great little inferior iridotomy. It cauterizes as it cuts. So you make a great little iridotomy with this thing, and this is not disposable, it's reusable, and you get no bleeding. So now that the iridotomy is done, decimetorexis is completed, I just reform the chamber a little bit with some saline, and now it's time to inject the graft. Because I have a big wound, I can just stick the injector straight into the wound without needing a forceps assist. And because the wound is big, also it leaks a bit around the injector, so I don't jack the pressure up inside the eye. I remove those little accompanying bubbles that come in with the graft, And now I'm looking at the orientation to see if the graft is right side up or upside down. That seems upside down to me, so I'm going to flip the graft here by injecting through the paracentesis while I push on the para, and that tumbles the graft over. And that's right side up, so just a few little taps on the corneal surface. I'll shallow the chamber because that increases the compression between the back surface of the cornea and the front of the iris, which helps me iron out these little folds. I have my orientation mark up there superiorly, and that indicates the lie of the graft, the orientation of the graft. So that's how you do DMEK in a 4.5 minute long procedure in an eye that you might think would actually be a little challenging because it's a phakic eye of a young, nervous patient. But you'll see there really was nothing special to any of those manipulations. Everything was very predictable and standard and routine. And some of that is because, we do all of these procedures in our office-based operating environment. My staff who helps me with surgery, these are the same technicians that see patients. These are my scribes. These are the people that see the patients in the clinic. On Thursday, when we do surgeries in the office, these people just migrate over. Now their job is to help with surgery. So these people are all intimately familiar with the patient. They're intimately familiar with the diagnostic and the disease entities. So it probably makes us a little bit better as a team working together in surgery. The fact that we don't use IVs also helps us with our efficiency because we don't have to fumble with getting them in or taking them out. It makes things just go much quicker and much smoother. As far as the surgery itself is concerned, the things that make it quicker and easier for me to do are the fact that we use topical anesthesia, the fact that we do our decimetorexis under air, and sort of conceptual knowledge about how to manage the graft inside the eye. In this eye, this phakic eye with a shallow anterior chamber, the key issue was, well, the graft was injected upside down and you have to flip it over. So how do you do that? Well, it's by jets of fluid through a paracentesis while you depress that wound. If you have that conceptual knowledge embedded, then it makes the operation trivially easy to do, actually much quicker and simpler even than normal cataract surgery. So I show this video because if you are thinking, well, gosh, I would like to switch from DSEK to DMEK, and I'm a corneal surgeon, but I worry about the technical challenges of this operation. It's actually probably an operation that you can master in less than 5 minutes, so it shouldn't be an overwhelming stressor for you. And if you are a patient watching this video and you think, oh my gosh, it's so scary, it's an operation on my eye, you might be surprised at what a not big deal the experience actually is. Probably from start to finish, it's more like a 4-minute procedure. For many people, even many challenging people, it turns out to be a quick operation. So don't be overwhelmed, don't be intimidated, give it a try. You'll probably be pleasantly surprised.